Hello, everyone, and welcome to today's webinar on heartburn and ND's action plan to eliminating acid reflux. Dr. Sandberg-Lewis is a 1978 NUNM graduate. He has authored two medical textbooks, practices in his clinic, The Hive Mind in Portland, Oregon. He has been a supervisor, professor since 1996, specializing in naturopathic gastroenterology, and won the 2019 Gastro ANP Board Marugnus Award. That's a really big word for belching. That's the medical word for burping. The gastro folks have a sense of humor. And in this past year, he received the Oregon Association of Naturopathic Physicians Living Legend Award. I'm super excited to present to you Dr. Sandberg-Lewis. And just want to provide a disclosure that this webinar is for educational purposes. Nothing in here is intended to serve as any medical advice in any form or fashion. It is also not eligible for continuing education. Reproduction is only allowed with expressed permission, and we typically do not allow the promotion of personal products. So Dr. Sandberg-Lewis, as I mentioned, is an author, but does not have anything further for disclosure.
Hello, I'm sorry that Zoom and I weren't communicating well this morning. Yeah, well, we are going to speak about unique ways to look at reflux and heartburn and ways to treat it, mostly with natural and habit change. So the first slide just really talks about some very basic things. This next slide, it just points out that a little bit of reflux is normal physiology. After almost every meal, the average person will have 3 little episodes of reflux, but there are lots of mechanisms in place that just take care of it and leads to no symptoms or damage to the esophagus. And I just like to point out that you don't have to have any change to the esophagus in order to have a diagnosis of reflux, because reflux in the healthiest people and the people with the highest melatonin levels in their esophagus don't get any damage at all to their esophagus. It looks completely normal, and that's called NERD, or non-erosive reflux disease. On the next slide, we have the basic protective mechanisms that are present in the esophagus. So there are glands that secrete mucus and also alkaline substances like bicarbonate that neutralize acid should it come up, and that's normal activity. The lower esophageal sphincter at the bottom of the esophagus normally prevents things from coming up from the stomach, at least minimal reflux. And then as the esophagus contracts, the peristaltic wave and saliva that's being swallowed every 30 seconds on average during the day is going to help to neutralize and wash down any material that's reflux. And of course, a healthy saliva has a neutral to slightly alkaline pH. On the next slide, just to remind people that there are different parts to the stomach that I might talk about. But the LES there, the lower esophageal sphincter, is shown in orange at the very bottom of the esophagus where it meets the fundus and body of the stomach. The antrum is the very lowest part of the stomach where it meets the pyloric valve that leads into the small intestine, here shown as the duodenum. On the next slide, we'll just take a really quick look. This is the kind of damage that occurs with reflux when there are changes in the esophagus. Different grades of reflux esophagitis, where you actually get an erosion of the superficial layer of the esophagus due to inflammation, acid, and digestive enzymes. Next slide. I'll let you look back at this if you like. But these are basically the different methods to really determine if there is reflux and if damage is being produced from the reflux. These are different kinds of tests that gastroenterologists use. The next slide, just quickly, typical symptoms: heartburn, which is a burning or pressure sensation that's usually over the sternum, breastbone. Regurgitation is when fluid from the stomach actually comes up into the esophagus, throat, or mouth. And I just like to point out that some patients there at the bottom, some patients have symptoms that they call GERD, but they really don't have any reflux. And in those cases, it's called functional heartburn because there really is no reflux. The next slide, I like to point out that LPR, or laryngopharyngeal reflux, is a type of reflux where people don't have that typical burning or heartburn over the breastbone, but instead they have symptoms in their voice and throat. So chronic hoarseness or a cough, non-productive cough, or increasing symptoms of asthma. At worst, sort of a waking up at night with choking and feeling like they can't get a breath, which can be really frightening. Chronic sore throats, chronic sinus problems, chronic ear infections, and aggravation of sleep apnea. So some people do have actual reflux without heartburn. Instead, they have these larynx and pharynx symptoms, voice box and throat. Again, I really like to point out the mechanisms that cause gastroesophageal reflux and not just assume that it's all about acid. The next slide just kind of, again, shows a little cartoon of a woman holding a glass of wine and just pointing out that the esophagus goes down, meets up with the stomach at the lower esophageal sphincter. And the next slide has that little bubble in the middle, blue bubble, that says reflux symptoms. So this is kind of the real pay dirt here. These are the most common things that cause symptoms of reflux, whether or not the person has damage to the esophagus or not. So at the top, we have visceral hypersensitivity, which is when the muscles in the esophagus, contraction feels like pain. That's a bad thing because they have to contract to function properly. But some people perceive that as painful. The next one to the right is delayed gastric emptying or gastroparesis. That's when the stomach doesn't release its contents adequately. Normally within 4 hours, a good 90% of the food from a meal will have moved on from the stomach into the small intestine. But if it doesn't, if it's delayed, then there's more pressure and more fluid and material to reflux up into the esophagus. The third one is hiatal hernia, which is when a portion of the upper stomach actually moves up into the chest. It creates a little mini stomach there that can cause a lot of reflux and other symptoms. The next one down is decreased protection, such as abnormal saliva. So for instance, people that have the autoimmune disease, Sjogren's disease, they make almost no saliva. And people that are very anxious make less saliva and stickier saliva that doesn't lubricate well. Saliva is really important. Like I say, you swallow it every 30 seconds during the day, and it bathes the esophagus in alkaline fluid and very protective fluid that has all kinds of wonderful protective substances in it. So if there's abnormal saliva due to anxiety or autoimmune disease or other problems, that's going to be a risk factor for more symptoms. The next one going around the circle is reduced esophageal clearance, and that's basically just when the muscles of the esophagus move things down, they also move down any refluxed material from the stomach. So if there's abnormal function of those muscles that control peristalsis in the esophagus, that's going to be a risk factor too. And the last two, we have bacterial overgrowth, which is overgrowth of bacteria usually in the small intestine, which backs up into the stomach and causes increased pressure, pushing things up into the esophagus. And the last one is when there's reduced pressure in the lower esophageal sphincter, or LES. Remember that LES is necessary to create that protection from upward movement of stomach contents into the esophagus. The next slide just kind of shows a woman listening to a pregnant woman's abdomen. These are just all the things that can increase that intra-abdominal pressure, that pressure below the diaphragm, that can tend to push things up and cause reflux. And the last one, I'd just like to point out, the last one is breath holding. When you exert yourself and contract abdominal muscles while holding your breath, that really increases the pressure in the abdomen, which can make reflux more extensive. Not a good habit. The next slide shows the lower esophageal sphincter, and it's kind of a interesting picture. It's a cross section of the lower esophageal sphincter, which is that pinkish red. Those are a cross section through the muscles of the lower esophageal sphincter, and then that brownish and whitish areas in the middle are the lining of the esophagus, and then after that Z line there, that zigzag line, the squamous-columnar junction, we see the tissues of the stomach. Just one thing to really note there is the diaphragm, which is those wings coming out, also in pinkish red, and it says there on the right, diaphragm. The diaphragm is a muscle, a big dome-shaped muscle that separates everything that's in the abdomen and everything that's in the chest. And it wraps around and hugs the lower esophageal sphincter, so it really strengthens that. So anything you can do to improve your diaphragm tone and strength is really helpful to prevent reflux, because it strengthens the lower esophageal sphincter. The next slide says GERD is all about excess acid, right? Or wrong? And again, a little bubble drawing there with the blue reflux symptoms. Over on the left, we have true acid reflux. Some people are refluxing acid into the esophagus, and that can cause erosive esophagitis, which is damage that we saw before to the esophagus, sloughing of the outer cells, or non-erosive disease, NERD, where there is no damage. Either one can be caused by acid reflux. Neutral reflux in the middle, or weak acidic reflux, can also cause the same symptoms. It doesn't have to be strong acid. And even neutral fluid can cause the same symptoms because of pressure. And then over on the right is functional heartburn, where people really don't have reflux, but they have symptoms anyway. They're going to be treated differently. The next slide just shows that people that take proton pump inhibitors for gastroesophageal reflux, they end up with less acid, so weakly acid, but it doesn't change the fact that they're having reflux. So it's still going to reflux into the esophagus, and they can have persistent heartburn symptoms even though they're taking a proton pump inhibitor. About 40% or so of people that take proton pump inhibitors don't get magical relief. This is one of the mechanisms. The next slide just points out a study, research study that showed that weakly acidic reflux could cause persistent symptoms in people taking proton pump inhibitors. And the next slide says GERD and distension. When they do studies and put a balloon into the esophagus, if they distend it, even in healthy patients, there will be some pain, either chest pain, feel like chest pain, or it can feel like heartburn. that pressure can cause either pain or burning. And this is true in people that have heartburn and people that don't. If you takes more pressure usually to make symptoms in people that don't have heartburn. But this is just showing that muscle contraction and pressure can be symptoms, can be causes of symptoms like heartburn or chest pain. I wanted to mention too that in this next slide, types of adiposity and GERD, meaning weight gain, people that have what we call apple fat have almost twice the risk of developing erosive esophagitis, damage of the esophagus from reflux. But good news is that people that have what we call pear-shaped obesity, or more weight around the hips and buttocks, actually have protection against erosive esophagitis and other dangerous complications of reflux, and have less of an issue with type 2 diabetes and cardiovascular disease as well. So not all increased weight is the same. This slide here, I think, could really be the last slide because these are all the lifestyle hacks that are so important. They don't apply to everyone, but if you see something on this mnemonic, reduce carbs, relieve reflux, CARBS, if you see something on there that is part of your lifestyle, it's worth trying a shift in that to see if it will make a difference. And when we go into question and answers, I can answer more if there's any specific questions about, for instance, C for soda, cola, coffee, chocolate, cigarettes, tobacco. Each of these different items that has been studied with empirical research to show that these things can trigger or increase reflux in people. You don't have to give them all up. You just have to figure out which ones really affect reflux in a particular patient. So C is for carbs, soda, coffee, chocolate, and tobacco. Cola or soda in general, because of phosphoric acid, tends to really acidify the esophagus, and it can stay in a more acidified state for up to about 12 or 13 minutes after drinking it. So it's one more factor there. Coffee and chocolate do affect the tone of the lower esophageal sphincter, and so do cigarettes. Cigarettes, of course, are direct toxins. Tobacco and tobacco smoke, direct toxins to the esophageal tissue as well. And cigarettes are the only thing, or smoking is the only thing on this list that's actually a known risk factor for Barrett's esophagus, which is that precancerous change that occurs in the esophagus with chronic reflux. A in carbs is for alcohol, which is toxic to every cell in the digestive tract, every lining cell, and also affects the lower esophageal sphincter. Acidic foods, acid foods seem to really trigger certain people, especially I think people with more erosive esophagitis, more damage to the esophagus. But acid foods can actually improve reflux in studies that show that lemon, orange, and even tomato, for some people can actually improve their refluxes. And I think these are especially people that don't make as much stomach acid. And then, of course, aspirin and ibuprofen and other anti-inflammatory medicines are known causes of erosions and even ulcers in the digestive tract, including the esophagus. R is for refined carbohydrates, and really too much carbohydrate in general. Research shows that a lower carbohydrate diet tends to really reduce reflux. And all the diets that I talk about with patients, 5 or 6, 7 different diets, they all have a relatively low carbohydrate intake compared to the standard American diet. Another R is rapid eating. So a study that had people eat a meal in 5 minutes and the exact same meal the next day in 20 minutes, people had a lot more reflux with the 5-minute meal due to less stimulation of the parasympathetic rest and digest nervous system. And then the last one is RX. There's a lot of medicines, prescription medicines that can trigger or increase reflux. And those include asthma medicines, calcium channel blockers for high blood pressure, beta blockers for high blood pressure, and bisphosphonate medicines for treating osteoporosis. The next slide, the B in carbs, is big meals. So overeating is a risk factor. Having a bigger waist circumference, we talked about that with the apple fat. And then bedtime eating, or eating within 3 hours of going to bed. I think everybody talks about that one. It's a real common issue that can cause the stomach to be fuller when you lie down at night, and without gravity to move things down, even more likely to have reflux when you're lying down. And that's even more so if you have a hiatal hernia. And then the last letter, S, snacking. So there are studies that show that people that just have 2 or 3 meals a day and have nothing but water in between meals have a lot less reflux than whether they're snacking throughout the day and eating frequently. And many of the diets that we use that concept. We call it meal spacing, to give the stomach time to empty. The next one is sleep position. So lying on the left side seems to be the best position. If you look at pictures of the stomach when you're lying on your right or left side, you'll see that when you're lying on your left side, the fluids in the stomach are at the lowest portion of the stomach and more protected from going up into the esophagus. Also, raising the head of the bed or using an angle pillow or several pillows to prop up the body, or sitting in a more 45-degree angle or something close to that has also been shown to reduce reflux during sleep. Shallow chest breathing, like I said, anything you can do to tone the diaphragm muscle and breathe into the abdomen rather than just in the chest helps to strengthen that muscle that hugs the outside of the lower esophageal sphincter and strengthens the lower esophageal sphincter. Studies on fat haven't shown as much of an issue as carbohydrates in the diet as a risk factor, but fat in general does slow down the emptying of the stomach. So people who have slower emptying, eating a higher fat meal could definitely be a risk factor for reflux. Spicy food studies, some studies show that if you just eat spicy food once in a while, that can trigger your reflux. But if you eat it all the time, your body gets used to it. So that's really can go either way, and it depends on the spice as well. And also under S is sensitivity to specific foods. So some people, there's just one particular food that really triggers them, such as white potato or onions or something very specific. And I just wanted to point out that some books on reflux have whole chapters on melatonin. Melatonin is really important for protecting the mucous membrane of the esophagus and the stomach. And I think I mentioned before that folks that have the highest melatonin in their esophagus and in their blood, even if they have reflux, significant reflux, they have the least damage. They tend to have NERD, the non-erosive reflux. as opposed to people with lower levels of melatonin in their body, either get esophageal erosions, erosive esophagitis, that real damage, or even worse, peptic ulcers if they have the lowest of all levels of melatonin. So it's a very important protector of the entire mucous membrane, especially esophagus and stomach. Well, we can talk about these, quickly go through these natural treatments. So again, this is based on some of those mechanisms that we talked about, mechanisms that cause reflux or increase reflux. So if you can tailor your treatment to the cause, it's much more likely to work than if you just use some general treatment. So if we want to enhance the defenses of the esophagus, things like DGL, which is deglycyrrhizinated licorice. This is a form of licorice that doesn't raise blood pressure or cause any changes in adrenal hormones like regular full licorice can do. And it's used specifically for the digestive tract to protect it. Aloe vera has been studied. In one study, it was as effective as omeprazole, the proton pump inhibitor, for treating erosive esophagitis pain. Zinc carnosine is a type of zinc specifically for the digestive tract, can help cytoprotective. It protects cells in the GI tract, and it can help to heal ulcers and erosions. Quercetin, there's a study of quercetin, which is a natural substance made from maritime pine bark, together with vitamin E, that was very effective for treating the symptoms of heartburn and compared very well to proton pump inhibitors for symptoms. Turmeric, of course, is good for everything. It's been studied as a way to help heal erosions in erosive esophagitis and help prevent them in people undergoing stressful situations like surgery. Melatonin, I mentioned before, is the guardian of the lining of the GI tract. It's an important antioxidant and protector, and helps to improve even blood flow through the esophageal lining, which is really important for protecting it. D-limonene is an extract of citrus peel, which is also cytoprotective, protects the cells, and is used to not just treat heartburn, but also to treat erosions and ulcers. On the next slide, it says improve gastric emptying. So like I said, if the stomach is slow to empty, we want to work on things that, there are lots of prescription and non-prescription treatments to improve gastric emptying, but diet factors are important, such as smaller meals, less insoluble fiber in meals, and reducing fat. Because like I said, fat in meals tends to slow down the emptying of the stomach. And then there are many herbal and prescription prokinetics. The simplest ones, most basic ones herbally, are iberogast, which in research is sometimes called STW5, and which is an herbal combination that includes Iberis amara, which is a very effective prokinetic herb, helps move things through the stomach into the small intestine. And ginger is probably the most available to almost anyone as a prokinetic, and that's one of the reasons why it's good for nausea, because it keeps the stomach from holding on to food too long. And then some natural treatments for the lower esophageal sphincter. Again, melatonin. Also, huperzine A, which is an extract of a Chinese herb that helps to increase acetylcholine, that very important neurotransmitter that controls the lower esophageal sphincter. And lecithin or phosphatidylcholine, which is a precursor to acetylcholine because of the choline in it. Strengthening the diaphragm by doing diaphragmatic breathing exercises. And then there are a couple of devices. There's a Stretta, which is actually kind of medical device that's put down through the esophagus and stimulates lower esophageal sphincter muscle tone using natural light frequencies, and something called iCoro, which usually the Q is capitalized. And that's a device from England that's a very simple little plastic device that helps to strengthen the muscles everywhere from the lips all the way down to the lower esophageal sphincter. The next slide, natural treatments for improving gastric emptying. I already mentioned these. So ginger, iberogast, and sometimes also it's been studied ginger and artichoke in combination. For people that have overgrowth of bacteria or archaea that make gas, hydrogen and methane gas, these are some natural treatments: oregano and berberine containing herbs such as golden seal, some probiotics like Lactobacillus reuteri, and a 3-herb combination called Atrantil, which is specific for methane, intestinal methane overgrowth. Lots of wonderful treatments for sliding hiatal hernias. I teach doctors to do a visceral manipulation, sort of a massage technique that's specific for this. There are many different kinds of manipulation techniques like that. I mentioned avoiding holding your breath during core exercise, abdominal exercise. Just keep breathing, and reducing gastric and intestinal pressure by either treating overgrowth or eating smaller meals. Lots of good ways to reduce pressure. The next slide are some natural treatments for people who actually don't make enough acid, can have the same symptoms because of pressure in the esophagus as people who make too much acid or normal levels of acid. So they can get tremendous relief from improving their production of stomach acid by using bitter herbs such as gentian, dandelion root, or bitter orange. There are others as well. Vinegar, small amounts of vinegar, like 1 or 2 teaspoons of apple cider vinegar and a 1/4 cup of water taken while you're preparing your food, 10 or 15 minutes before meals, or actual betaine hydrochloride capsules that actually contain stomach acid and pepsin. And then there's this thing called the acid pocket, which means that the very upper surface of the fluid in the stomach is the most acid part. They call it the acid pocket. And that's where different products like Gaviscon and Reflux Gourmet, Reflux Raft, Esophageal Guardian, products that contain sodium alginate made from seaweed, that seaweed gel will float on the top of the stomach contents and prevent it from refluxing into the esophagus. And many people can use this as a non-drug treatment with very good results for treating reflux. And lastly, water is very important. Drinking enough water, which is usually about 2 liters a day for adults. Using moderate versus really intense, acute, strenuous exercise. That study there talks about how reflux and other GI problems can be caused by acute, strenuous, intense exercise. And then alkaline water really does seem to be magical for some people and actually just gets rid of all their symptoms of reflux. pH water up to 8.8 as opposed to regular water, which has a pH around 7. And the last slide there shows surgery for the stomach, Nissen or Toupet gastric fundoplication surgery. And you can see they're pulling the fundus of the stomach around to the front and sewing it to itself, creating a little turtleneck sweater, so to speak, to keep the stomach below the diaphragm if there's a hiatal hernia, and to strengthen
the lower esophageal sphincter by wrapping more stomach muscle around it. Of course, the esophagus can do that if the esophagus is in the right spot and is in good tone. Let's make this the final slide. Helicobacter pylori. Probably everyone's heard about H. pylori as a cause of ulcers. I just like to point out to doctors and students and patients that Helicobacter pylori, in virtually every study that's been done, and several meta-analyses have been done, in almost every study, virtually every study, it protects against reflux. It protects against the negative effects and complications of reflux, such as Barrett's esophagus and cancer of the esophagus. So I don't even test my patients that have reflux for H. pylori because I don't want to kill it if they have it, unless they have other symptoms or signs that make me need to test for it. So I just want to point that out. Most people think H. pylori, you just need to kill it in everybody, but it actually protects against allergies, Crohn's disease, reflux, and its complications. Seems like a good place to stop.
Thank you so much, Dr. Sandberg-Lewis. We have a couple of other slides here, and we can get to some questions as well. You had one slide regarding what you love about naturopathic medicine, if you wouldn't mind sharing. Yeah.
What I love about naturopathic medicine is that it is one doctor once comically said naturopathy is 1 inch deep and a mile wide. And what they mean by that is that we're really generalists. We know a lot about many things. Some of us have more than 1 inch deep in certain areas, but it's the idea that naturopathic medicine is so broad. You'll never get bored if you decide to become a naturopathic physician. If you're a lifelong learner, you will constantly have new things to explore that will help your patients.
Do you have any tips for future NDs or people considering this profession?
Yeah, the tip that I thought of this morning is that don't give up your art, because medicine and naturopathic medicine is both art and science. So don't think if you're going to become a physician, you have to be a scientist and give up your art. It's very important. And I would also say that doing your own personal work, whether it's emotional, spiritual, physical on your own body, but especially emotional and spiritual work is really important. The best doctors, I think, are people that can lead their patients through difficult times and experiences, and people can really feel it if you've done your own work.
Thank you. And I've got Dr. Sandberg-Lewis's contact information up on the screen here. Uh, there are a couple of questions as well that are coming through. I already discussed the upcoming events that we have in November and December. We hope we will see you there. Dr. Sandberg-Lewis, if I can just share a couple of questions that have come through. We have time for maybe a few of them. So can you share in general terms, without outing any specific companies, how you go about sourcing and making sure that the companies that you're using are good and effective, and how you understand the side effects from natural treatments that you may be prescribing for patients?
Oh, I understand the side effects. One thing I have to say is that some people, a lot of people that I see, because they've been sick for a long time, their detoxification pathways in their bodies are compromised. And many people also have an issue with their own inflammatory chemicals in their bodies, such as histamine. And therefore, these people will be really sensitive to almost anything in their environment. Sometimes it's not even an actual medicine or herb, but it's something about their environment other than that. But it's important to realize that you can react to any natural substance, and some natural substances come as pure substances, but most are in capsules. They have fillers, they have flowing agents, and different things that are involved unless you're just using tea. And people can react to all of those things. So it's not always the active substance or the herb or natural substance that a person is reacting to. It could be any host of other what we call excipients, things that are put into capsules or tablets or other methods. So I find that's a big problem. Another thing is that herbs do a lot of things. If you give somebody golden seal, not only are you killing bacteria, viruses, and fungus, but you are also reducing their blood sugar if they have high blood sugar. You are starting to heal the membrane of the GI tract. So many factors go into complicated things like natural substances like herbs, as opposed to drugs that usually, have one agent. An herb might have hundreds of different components in it. So, kind of a long answer, but these things are really complicated, and there are lots of things to react to. So don't always throw out the baby with the bathwater if the person has a negative reaction.
Perfect. Thank you so much. There's a question if you could elaborate more on gastroparesis a bit.
Yeah, gastroparesis, most common cause is insulin resistance, prediabetes or diabetes. In fact, up to 50% of type 1 diabetics and about 25 to 30% of type 2 diabetics have gastroparesis or slow emptying of the stomach. And that's especially perilous for people that have to inject insulin because it can create a mismatch between the insulin that they're taking and the food that they're eating, because the food isn't, the carbohydrate in the food isn't being absorbed until it enters the small intestine. If the stomach doesn't empty quickly enough, the insulin's there without the carbohydrate, and their blood sugar could drop to very dangerously low levels. But the main thing about gastroparesis and delayed gastric emptying is people tend to have more reflux. They tend to have nausea and just a feeling of fullness. They feel like the meal they ate 6-8 hours ago is still there, and so they lose their appetite. They don't want to eat. And that makes sense because the food is still there, more so than it should be. It hasn't moved through into the small intestine. So this is a real issue, and there are other causes besides blood sugar issues, such as traumatic brain injury and taking narcotic medications. But there's even a post-viral type that's more common in children. This is a big problem and can cause pretty severe symptoms. So besides GERD.
Well, Dr. Sandberg-Lewis, I thank you and thank you for hanging in there with the technical difficulties that we faced here and bearing with us as we found a solution. I think this was a really informative talk, and we're going to wrap up now. We have included your contact information for folks who have further issues or questions rather, and would like to get in touch with you. We've also like to mention the Gastro ANP, which is a specialty organization for doctors that focus on gastroenterology, and that's a good place to find other NDs who may help with issues surrounding some of the things we've talked about today. So that said, thank you so much for sharing your brain space with us all today, and I look forward to seeing you all at a future event. Thanks for coming. And thank you, Dr. Sandberg-Lewis.
You're welcome.